Nurses, and welcome to the Adventist Fort Washington Medical Center Reverse the Cycle Nurse Training. Today we'll be talking a lot about the Reverse the Cycle program that has been launched at your hospital, understanding the role the nurses play in this program, including screening for risky alcohol or other substance use, and conducting the clinical opiate withdrawal scale assessment for opiate using patients. Just a little bit of a background on the program and some rising statistics. Over the last few years, there's been a significant increase in substance use and substance use disorders across the U.S. I think it's no surprise that the COVID pandemic has significantly increased this typical increase year over year, and we're seeing higher numbers of overdose deaths, substance use, and substance use disorders than we ever have before. The Reverse the Cycle is a comprehensive hospital program that includes three components that I'll go over today. This was brought to you by Mosaic Group. I did not introduce myself, but my name is Heather Raley. I'm a licensed counselor. And with Mosaic Group, I'm a senior behavioral health consultant. And we worked with the Prince George's Health Department, as well as the Adventist Healthcare Network, to bring Reverse the Cycle to your hospital center. Additionally, throughout 2022, we aim to integrate this also to the other two hospital campuses of the Adventist Healthcare Network. The three components include universal screening and peer intervention, the OSOP program, which stands for the Overdose Survivors Outreach Program, and MOUD, or Medication for Opiate Use Disorder Initiation in the Emergency Department. So the program looks a little like this comprehensively. All emergency department patients are screened for risky substance use by nursing staff after triage. The medical record, or your Cerner program, alerts the peer recovery coaches within Cerner if a patient has screened positively for risky substance use. The peer recovery coach then reviews the screen, the patient chart, meets with the patient, and provides a brief intervention, working with the patient to enhance motivation for change. The peer recovery coach then develops a plan, which may or may not include substance use treatment, and assists and supports with any appointments and referrals. So the team, your peer recovery coaches, are individuals who are in long-term recovery themselves. And so this drastically changes the dynamic of the interaction with the patient. The peer recovery coaches are people who've been exactly where they are. They struggled with substance use disorder or alcohol use disorder or both, and they're currently in recovery, and they're aiming to help others achieve recovery as well. They're trained in motivational interviewing and substance use disorders. And they staff the ED most weekdays from about 8 or 9 a.m. until 12 midnight. There are some days when there's only a mid shift on, which is 10 to 6:30. And on weekends, they staff 10 to 6:30. They provide support to patients with risky alcohol or other substance use. They're very well connected to community resources and treatment facilities statewide, and they assist the team by providing resources and completing referrals to treatment. So how is this implemented specifically at Fort Washington? Well, all patients who come in through the ED are screened upon each encounter, and they should only be screened one time upon each encounter. So if the patient is discharged and comes back to the emergency department later that day, they should be screened again. However, if they were screened initially on day shift, they do not need to be screened again on evening shift. Patients will be screened as part of immediately following the triage process, and there'll be an ED launch point alert following the completion of the ED triage form, meaning after triage, a number of tasks will populate, including the expert screen. It can be accessed from the activities section of ED launch point. And the expert screen contains two components: the audit C, which is the alcohol use questionnaire that generates an actual score between 0 and 12, and two drug use questions. So how do you access this in Cerner? So as I noted, there is an ED launch point alert that pops up indicating that the expert screen is needed. This is expected on all patients who are able to verbalize and understand the question. You would click on the blue, complete the expert screening. You're able to see if a patient has already completed the screening under assessments. If it's already complete, please do not complete it again. The expert screen looks like this. So as I noted, there are three questions that are included in the audit C, or the alcohol use disorders identification test. Upon asking the patient, how often do you have a drink containing alcohol? If they say never, then you don't need to ask questions 2 and 3. If they say not that often, or I don't really drink like that, or just socially, they are drinking at some level. So please ask some more details about how often specifically they're drinking. A few times a week, a few times a month, more than that, less than that. That will then, if anything other than never is selected, that will then indicate that questions 2 and 3 need to be completed. Once these 3 questions are completed, an SBIRT score will populate where this red box is. So that is a score between 0 and 12, indicating the level of alcohol use. That has nothing to do with drug use. And so this score, if it's 7 or above, will then trigger that patient to the peer recovery coach. It is very important that you ask the questions exactly as noted. Please don't just ask the patient, do you drink, do you smoke, do you do drugs? This is a validated assessment, and it only receives validated answers if asked exactly as noted. And please note that social drinking or not drinking that much does require all 3 questions to be asked. Again, if that score is below a 7, they're not going to be triggered to the coach. So you don't have to worry about patients who are drinking at a low risk or even low moderate risk level to be triggered to the peer recovery coach. The 4th and 5th questions are related to drug use. We recommend that you ask within the last 12 months. We've been unable to update this form thus far. Hopefully, we're able to update it soon. But we're only looking for substance use within the last 12 months. So asking a patient, have you, within the last 12 months, even though it notes ever used, illegal drugs or prescription drugs for recreational purposes or non-prescription purposes? We also encourage you to ask specifically marijuana or any other drugs. We understand that in DC, this is legal. We understand in Maryland, marijuana is decriminalized. However, there is a risk associated with purchasing anything from somebody off the street in any place other than a dispensary. So we want to make sure that patients using just marijuana are screened positive as well. The second question asks specifically about heroin or opiates. While it does state, have you ever, we do ask that you are permitted to ask within the last 12 months. Now, if a patient is prescribed Percocet, Vicodin, Oxy, and they're taking it as prescribed, the answer to this would be no. However, if they're taking more than they should, somebody else's prescription in the last 12 months, then that would be a yes, and that would be a positive screen. You don't have to answer these next 3 questions. They will populate automatically. This just indicates, first, if there's an alcohol score of a 4 or above. The next indicates if there's an alcohol score of a 7 or above. The next indicates their readiness to change. There is a readiness to change gauge on the SBIRT assessment. You do not have to ask that either. This form has lived in your Cerner system for much longer than this program has been apart. We're working on changing it. However, we do ask that you don't need to complete the readiness to change score. You do not need to populate any of these questions, only the 3 Audit C questions and the 2 drug questions. If a patient scores a 7 or above on the Audit C, or answers yes to using illegal drugs or prescription medication for recreational purposes, or heroin or opiates, they're a positive screen. And this would trigger a consult order and populate this patient on the peer recovery coach's multi-patient task list in Cerner. And just a summary of positive responses. The second component is our OSAP program, our Overdose Survivors Outreach Program. This is a program that is primarily community-based, and this coach will be out and about in the community providing hands-on resources, connections in the community. And so we know that many of our patients who need substance use treatment need a lot more than just substance use treatment. So if there are any other social needs such as housing or insurance or jobs or just additional support out in the community, this coach will be there to work with them. They'll provide intensive outreach and follow-up in the community, not only to overdose survivors, but for the case of Fort Washington Hospital Center, they'll also provide this additional support to any patients who identify as opiate using or using PCP. And so the patients in the emergency department who are there for overdose or intoxication, any high-risk patients using opioids or PCP, the peer recovery coach will initially see them, will discuss the OSAP program to them, will discuss any risks or side effects of naloxone administration if this is appropriate for the patient, and then introduced to the OSOP coach. And the OSOP community recovery coach connects the patient ideally within 24 hours. Our goal is to connect with these patients as soon as possible because we know that they're the highest risk patients. They connect them with recovery support services, treatment programs, and also help coordinate their care. So the third component, the MOUD initiation in the ED or fast track referrals, or the medication for opiate use disorder initiation. And for these purposes, we're utilizing Suboxone. So patients who are experiencing withdrawal can receive a dose of Suboxone and begin to feel better. In the ED, they can receive this initial dose. It allows them to participate more actively in their treatment. Patients understand discharge better, and they're less likely to leave AMA. We also know that from implementing this program through Baltimore and through 50+ hospitals, that our patients who initiate their Suboxone in the emergency department, 70 to 75% of the time they attend that treatment appointment that is set for them. This is significantly higher than just another referral to treatment for opiate using patients without Suboxone administration. When patients feel better, they're less likely to use illicitly. And our goal is to reduce or eliminate that street purchasing, right? Because we know that that can be laced with anything and everything, and it's extremely risky. Patients who receive the dose are more likely to engage in treatment within 24 hours, and they're less likely to revisit the emergency department. One thing to be aware of is that we want to make sure that we're not dosing patients too soon. So if a patient has recently used, then they would not be administered Suboxone. However, they would be a candidate for this protocol because we don't know for sure how long they're going to be in the emergency department or in the hospital, and they may begin to experience withdrawal while they're in there. However, withdrawal is more likely when there's a physical dependence, short time since last opiate use, and the initial dose of Suboxone was too high. And so precipitated withdrawal means that the body thinks you're in withdrawal, but you don't have any opioids, and therefore the symptoms mimic withdrawal, and it's extremely painful for the patient. We prevent this by administering the first dose when there are objective signs of withdrawal present. How do we know when there are objective signs of withdrawal? By completing the clinical opiate withdrawal scale, or the COWS. You're familiar with the CWA, which is the alcohol withdrawal scale. This is very similar. I'll show you exactly where it is in your Cerner system in a second. But this is a method of recording symptoms for opiate withdrawal specifically. It determines the level of withdrawal, and the sum of the numbers determines the level of withdrawal and can help determine the next course of action. Nurses will be notified by the provider if the COWS is needed. So this is something that the peer recovery coach will talk with the provider and discuss their appropriateness for the MOUD or Suboxone initiation protocol. Then the provider, once deemed appropriate, will notify the nurse that the COWS assessment needs to be complete. The COWS assessment can be found in ED frequent monitoring. The COWS score ranges from 0 to 36. A score of an 8 or above means that this patient is very likely in the stages of withdrawal where they will not experience precipitated withdrawal and that they'll benefit from a dose of Suboxone. The doses of Suboxone that are carried by the pharmacy are 8 milligrams. And this is a combination of buprenorphine and naloxone. The administration, we encourage nurses to be familiar with how to administer this. It's a sublingual strip that will be administered. We recommend no smoking immediately before or after, no talking during administration. You don't swallow the tablet. It's a sublingual strip, starting with a moist mouth, avoiding any acidic acids, and not to swallow the entire tablet. Following the administration, there are no assessments that are needed. You don't have to wait a certain amount of time before that patient can be discharged or reassessed at any point, and there are no side effects or contraindications, except, as noted before, the risk of precipitated withdrawal if given too soon. Then, as this is all happening, the peer recovery coach is working with the patient to connect them to a community-based substance use treatment provider. Now, the goal is not for the hospital to be the treatment provider, right? The reason that providers are able to administer one dose in the ED without an X waiver is because they are not prescribing Suboxone. They are administering one dose to alleviate acute withdrawal symptoms for which a waiver is not required. The existing network in the community that the peer recovery coaches are becoming familiar with are ready and available to accept our patients within 24 to 48 hours. So the goal is that that patient is dosed in the emergency department, they feel better, they have an appointment the next day, and they attend that appointment the next day, and the coach is setting this all up in the background. They also have protocols for off hours, what to do if a patient comes in the evening or weekend with regards to setting up an appointment or having that patient attend the appointment when the clinic or practice is open. The peer recovery coach will not recommend a patient to be dosed or for this MOUD initiation protocol unless the patient has confirmed that they will go to treatment. So this isn't meant to just help patients with alleviate immediate withdrawal symptoms if they have no intention of going to treatment if they're currently in a program. If they are currently in a program, the provider or nurse can verify their dose with the program of either methadone or Suboxone, and they can continue that dose in the ED or throughout the hospital stay. They don't need to initiate anything. They would just be approved to give the dose that the patient is already on. So in summary, the nursing staff will screen patients 18 years or older. Immediately following nurse triage, patients will who screen positive are triggered to the peer recovery coach. The peer recovery coach will conduct a BI or a brief intervention and develop a plan that may or may not include MOUD initiation. The peer recovery coach will document the brief intervention and plans for follow-up, and the peer recovery coach will provide a patient with a referral if appropriate. A lot of the conversations are going to be harm reduction or reduction of use, not necessarily referrals to treatment. And the peer recovery coach will schedule and complete follow-up based on this plan. Thank you all for your time, and please see either your peer recovery coaches or your nursing educator or supervisor if you have any questions.